I wanted to kind of kick it off, and I'm going to ask each of the panel members to respond. And the first one is, I mean, everybody's getting a little bit tired of hearing of the word innovation. And I, for one, am getting a bit of innovation fatigue. There's a lot of talk about innovation, but we want to see it happen. And so perhaps I'd ask each panel member to kind of talk a little bit about what is your view of innovation and where we are at the moment in the health system. So, Ian.
No, start with Peter. He's the expert.
No, start with Ian.
Well, Michael, my own bias on the table, when I was in government for 2.5 years, I put out an order that no one was allowed to use the word competitiveness, productivity, or innovation in any federal government documents as long as I was working for the federal government. So for 2.5 years, I think we held the line on that. But as soon as I left the federal government, it was over, and we were back to innovation strategies left, right, and center. You know, whatever the original diagnostic of the economy was that led us to the obsession with innovation, if it's not empowering patients, it's probably not worth doing in the healthcare field. And there's a certain anarchist undertone to that, if you want, that we have to wrap our heads around, I think. And that's I think is the next stage that's valuable, because the tools are there for patient empowerment regardless, or for consumer empowerment regardless. And that's the innovation that's going to drive the system in the next 10 years, I'm convinced of that. We can either get our heads around that or not, but I think that's a better frame to look at it than innovation.
Great. Josée.
Well, I'm not getting fatigued, I think. For me, it's clear that the way we run our country and our society has all been invented in the 1960s, most of the institutions and all that, when the drivers and the population need were much different from today. And so this is why so many things need to be changed today, I think. So we have to invent a new way of doing what we want to do. And I think in healthcare, it's even more true. We still want great quality healthcare, but there's many more drivers that we didn't have in the 1960s. And so I think we're just at the point, it's not the time to get fatigued, I think, because we're at the point where all the investment we made in digital healthcare is about to pay off. I mean, I'm a patient in Quebec City, and I cannot say that I've seen great innovation so far from the digital health. When I go to the hospital, I still get asked about my medication list, and I wonder, why isn't it online somewhere? It is, I guess it's not complete and all that. So I think the patients are about to see the results of all the work we've been doing. So it's just time to accelerate and not be fatigued. I think it's to deliver the promise for the patient, I think, as opposed to just for the system. So.
Peter.
So one of the challenges with words is that they can lose their meaning. And there are some words like innovation that maybe sometimes need a holiday. As of 2013, there were 44 definitions of innovation. That's 4 years ago, so I imagine it's probably doubled by now. The one that I like, that has, I think, value, is a sort of a play on Everett Rogers' definition of innovation, which is really a product, service, or idea that's perceived as new by a person or a social group in a network over time. So I think that allows us to quantify, and that allows us to start to sort of not get hung up on what the word is, but actually have meaning to the word that can then frame it within the context of innovators, early adopters, early majority, late majority, and laggards. And I think that gives us something that we can actually quantify, because let's not forget, just simply because you have a good idea doesn't mean it gets adopted. It took 150 years for vitamin C to be adopted in the Royal Navy, even though there was really good case control evidence. And the mortality rate was something around 20% for the crews traveling from Britain to India. So it's not like just because you have a good idea that it's going to be adopted. We need to sort of understand the science of adoption as well.
Victoria.
Well, last person, so I have to think of something innovative. I think As Peter had said, I think that word sometimes can get tiring, but not the work behind it. And especially in healthcare, I think we saw some references to Commonwealth Foundation Fund and the work that was done earlier this year. And Canada ranked below average in terms of our performance, but it also noted that we're markedly lower in performance compared to others, and we're in the bottom 3. With the US and France. So I don't think that we're in a good place in terms of healthcare and innovation, and we're lagging. So in many instances, I think innovation in health system means that we're applying what's successful elsewhere in our setting successfully, and in a federated model where it's very challenging and complex. And I also think that there's differences in terms of innovation. There's what we term, and I'm afraid that we added to the number of definitions, because our organization recently went through defining innovation within our setting. And we talked about how we need to result in better outcomes for our patients, quality performance, but we also talked about small I in terms of smaller quality improvement measures to big I and more disruptive endeavors. So I think there's still lots of work in innovation in health system.
Absolutely. And I was going to ask a question to Ian. You may not all know, but Ian was Chief of Staff to one of our former beloved Prime Ministers.
Right.
And if you
I could dictate what words were used in government documents and not, yeah.
If you were the Chief of Staff today, what would your advice be to the Prime Minister about the federal role in health innovation?
Well, when I was in Ottawa, the byword was minimalist. More money over time, not massive amounts of new money over time, but substantial new money over time, and let the provinces do whatever they want with it. And, I think there's a cycle to this sort of thing. I think at that point, that was probably not a bad approach. The current government has a more ambitious approach through more complicated health accords and so on and so forth. I'm not sure that's going to pay off quite as well as they had hoped, but I think it was the time to be a little more directive about the federal role here, because the federal government obviously has tools at its disposal. That said, if the federal government can improve healthcare in the areas where it is the primary actor, for Indigenous First Nations, for Canadian Forces, for correctional services, and in some ways for the RCMP, then it's not really setting a very good example here. I mean, I think the instinct is always to use the federal levers to try and improve in the province's backyard. There's a role for that. I don't know how big it is, but there's a role for that. But the federal government has to focus itself on its own health services first. So the new Department for First Nations and Indigenous Services may be a good start to this. But the idea that you're going to move that dial without moving the Correctional Services one, or without the Veterans Affairs one, and so on and so forth, I have a bit of a problem with that. I don't think that's probably the best mobilization of federal effort here. But the federal government would like people sometimes to overlook the fact that it's a provider. It fulfills what is otherwise the provincial role for an awful lot of populations, and we want to make sure that that's improving as well.
Great, thanks. And I'm going to ask Peter, in the last 10 years you're a clinician, you're a technologist, a kind of futurist as well. What do you think has been the biggest innovation we've seen in the system in 10 years?
I'd say the iPhone and the app stores, the proliferation of apps. Really, healthcare has not changed a lot. I've been in healthcare for 45 years. 35 years as a physician. I started out in high school as an orderly in a psychiatric hospital during the one flew over the cuckoo's nest year. And so, and I was a medical ethicist going through school. I had a master's degree in medical ethics, and I was a paramedic to pay my way through school before I went into medicine. So the delivery of healthcare has actually not changed a very lot. Pretty minimal. I remember when I took over from an old guy, a GP, retired, and he had, like the pharmacist was saying, he had cards. They were like recipe cards. That was the standard medical record. And in fact, you got one card for the whole family. So if L and R, I thought was left and right blood pressure, but it was really Len and Rose. And so I didn't need to be upset when there was a huge difference between the left and the right. So I think the actual structures of delivery of healthcare has not changed very much. The innovations have been all around that. Now, having said that, I think we're at the precipice of an age that is changing, and you don't have to be a futurist to really understand that things like virtual care. I was down speaking in St. Louis to the 5 big HMOs a few weeks ago, and there's the virtual hospital in St. Louis, Mercy's Virtual Hospital, has been in existence for like 9 years. It's not new. They have no patients. No patients. They have doctors and nurses, and over 400 patients are treated virtually, remotely, I should say, not virtually, but really remotely, with better health outcomes, 40% reduction in length of stay, 40% reduction in cost, 50% reduction in mortality from sepsis. So they're using AI. They have a lot of partners like our initial speaker this morning. They're not doing it all themselves. So I think there's those kinds of changes that are changing healthcare on the outside. We have a system that's very much beholden to the what I call the post-medieval hierarchy of the guilds, which is all about preserving the power of the guild. The structure of service delivery is very much centered around that. So I think we're seeing rapid changes in digitization, in some ways outside of the traditional healthcare system, and many clinicians and patients are going around the healthcare system to be able to access communication amongst and between themselves. But that democratization of healthcare is happening largely, with few exceptions, outside the actual structure of healthcare.
So what could we do inside that structure then to make that change?
Why don't you ask Victoria that?
Good question.
Whoa. Well, that's a tough one, isn't it? Because we're where we are at because of the barriers. So maybe I'll talk a little bit about some of the barriers and then think through some of the ways that we can get around it. So I think some of the challenges that I've found in our health system is that health, and rightly so, is a very passionate area for many of Canadians, and it's often a political area for governments that are in charge. So it's usually an election issue, which means that healthcare, when it's governed politically, it's difficult to make changes because small changes become a political issue. I think on kind of a meso level, I think we're organized in large organizations, and large organizations have difficulties in innovating, even if it's in a private sector, let alone in a public sector. And then I think our healthcare system is staffed by people like myself, physicians, and also staff that are under collective agreements that are trained to be averse to risk and change. So all of that together, I think, add up to be quite a significant barrier in terms of internally, how do we change? So what I found to be helpful in terms of enabling change and innovation is through partnerships. So just to give you a tangible example, in Fraser Health, we partnered with municipalities and through academic institutions. We're a founding partner in creation of something called Innovation Boulevard, where we come together with common challenges in health and look for solutions outside of health system. So because we've become tunnel visioned in our area, we look for unusual suspects to hack our problems with us. And I think we've seen some successes through those partnerships in enabling change and innovation that way.
Do you think those get pushed into, how can we push them into the system? That's perhaps the biggest challenge, isn't it? To make those changes really come through and get into normal medical practice? Yeah,
I mean, I think if I were to learn from Peter, I would give this question to somebody else, but I'll go at it, given that I gave an example.
The clinician's view.
Yes. Yeah. I think the challenge of scale, and us being a pilot country, is well known, right? In terms in Canada, we often have successful pilots, in whether it's in digital health or elsewhere, and it's very challenging for us to actually implement and scale up those successful pilots. I think what we've done a little bit differently in our setting now is to think of scale from the beginning. So instead of working through a challenge and then saying, well, this is successful, now what do we do? We've put scaling up from our primary mandate, and I think at a broader level that needs to be done at federal and provincial, territorial levels.
Great.
Others want to take a crack on it?
Well, I think it's the patient that will bring the change as well. I think empowering the patient and putting the patient at the center of care is one of the elements. They will demand it, I think, more and more. And I guess so there needs to be a clear vision of where this needs to go. But as an example, in 2007, I was working in a startup in Quebec City, and we had developed a virtual care EMR and all that. And we said, okay, before selling it to the States, we'll launch it in Quebec. We'll launch a private virtual care visit. There was a need, so we're going to launch it. And naively, we put an ad in the newspaper to recruit doctors to do this. And on the next day, we were on the front pages of all the newspapers across the province. And the Ordre des Médecins du Québec was really adamant that if you do not see a patient in person, you cannot pose a diagnosis. That was 10 years ago. And they even sent a letter out to all their physicians saying that. So 10 years later, we're much more open to virtual visits, and I think, and even virtual visits don't have to happen with physicians as well, I think. So I think patient will demand it, and I think we also have to not think about using digital health on top of the existing system in the same way we're doing the current system. I was reading a recent article saying that there was a study, I think a very large study, but saying that the physician doing virtual visits ended up doing more in-person visit with this person because they weren't sure and what they said were and all that, so they were questioning whether virtual visits was the right tool. I think they were just trying to use virtual visit the same way they were using an in-person visit, and maybe we need to rethink the clinical pathway around how can we leverage these things and do things differently. So.
And again, Josée, I'd like to ask you, because you're very much from the private sector, what role do you think the private sector can play in this innovation approach?
That's a tough question, because what we did is we went to the States and started selling in the States, which was much easier than selling in Canada. And as our friend, the pharmacist, said earlier, there's so many different regulations and ways to do things, and you have to run so it's fragmented. I mean, the market is small and it's fragmented as well. So so I think there's going to be, I think what the private sector could do, if the data was available, there could be many more apps. You could do a lot with accessible, meaningful, and up-to-date data, I think. So I think the private sector could play a role in offering things. You already see remote sensors and all kinds. I was reading 20,000 apps. There is healthcare-related apps on the App Store. I don't know if that's right. There was a huge number of apps on the App Store related to health. So already this is happening, but maybe in Canada not with the right data. So I think there's a role to play as an influencer, I think, and as an innovator. But it has to be in partnership, I think. So
it was very interesting to hear Andrew Slater's talk this morning about what's going on in New Zealand, and I was particularly impressed by the approach that his organisation's taking with consumers. Is that an approach that Infoway should be looking at, Ian? Should we be investing more in our social media and really going direct to consumer to build that demand that Josée was just talking about?
Well, when I joined the Infoway board, I don't remember now, this is probably 6 years ago, we had a discussion about this. Because the board includes, provincial deputies and Health Canada associate deputy. The discussion with them was, how much can we light the bomb of patient demand, consumer demand, patient-driven, whatever. Are we worried about the system's ability to keep up with the patient demand if we really wire the system in such a way that enables that kind of patient-driven access to the system? And I think the sense that we had at that point from the provinces in particular was, let's proceed very slowly with that. On the other hand, I think in the course of the last 6 years, between Dr. Google and everybody else that's in this space here, I think the answer we would get today if we asked the same question is completely different. That it's inevitably going to be patient or consumer driven. It's going to be patient or consumer captured. I think we've had the discussion at Infoway, all of the problems of interoperability and alignment of systems and so on and so forth, the solutions are going to come from the patient demand side and from the iPhone side rather than from the big system side, and we have to think that ahead, because to give a less flippant answer to your original innovation question, the whole purpose of this, right, is to make it easier and to make it better. I mean, we can have a complicated discussion about the metrics of easy and the metrics of better. Is it less time consuming? Is it more timely? Are there fewer resources involved? Is it less capital intensive? Is it less equipment intensive? Can we make better use of this, that, and the other thing? It's all easier. And can we make it better? Is it according to some clinical metric or some kind of patient satisfaction score or whatever? There's lots of discussion to be had around that. But the whole objective is to make it easier, to make it better, right? And easier and better both for the providers, for the clinicians or whoever's on the providing side, and for the patient as well. Victoria's right about the indicators on the Commonwealth study and all the other studies that we have of comparative here. The distance that we have to go in order to make up to the international average for easy and for better is a long way, and therefore should not be that complicated. We have to get back to that discussion of the easier, better, and pretty quick in order to recapture that curve.
Great. So now I want to ask Peter. So if you were federal health minister for a day, what big innovation would you introduce to the system?
That's the hardest question on the list.
Well, you're the chair. Come on.
The obvious answer would be I'd ask my deputy.
Delegate.
That's what I'd do. I find it, the whole federal role, I think, as Ian's alluded to, is really around finance. And I think that, having had as a provincial deputy administrator and made a lot of change in a short period of time, understand that it's really difficult to make change. And so, being minister for one day, you don't really have an awful lot you can do. I think that it's ironic in some ways, coming back to Ian's earlier comments on federal role, that we have no quality legislation federally in Canada. And I think that says a lot, both in terms of the delivery side that Ian talked about, but also the opportunity to lead into this new age. I think there's opportunities in national quality legislation to really look, for me, quality and innovation, two sides of the same coin. And to be able to instill the structures that we need to be able to incent that and measure that and actually see outcome measurement from the change that we currently don't have. And I think that raises the bar all across the country in all the provinces and territories. So if I had my wish list, it'd take more than a day, but I think quality legislation federally would be the place to start.
Anyone else wanting to pitch in on that one? Ian, you look as though you got to.
Yeah, look, I mean, when I was in government, we had some very short timelines, which I think is normal in the political process, but shorter by the virtue of the fact that the election campaign I was involved in didn't get us up to a majority government. So we, at that point, we felt we were on a very short
agenda.
Yeah, short timeline, very uncertain timeline. We had run partly on a not quality guarantee agenda, but something similar to that. That really is probably a 5 to 8 year agenda. All the professional accreditation rules are at the provincial level, really. All of the prescribing and delivery rules are mostly at the provincial level rather than at the federal level. So to try to think, I mean, this is what we encountered when we tried to do this, is that, this is a 5 or an 8 year agenda rather than a 1 year agenda or a 1 day agenda, to give you your mandate to Peter of one day. So this is going to require some sustained thought and some sustained design. That said, there's almost certainly economies of scale to do this at the federal level. And my sense is that if you approached it politically in the right way, some of the professions would want to do it nationally if it meant a genuine quality discussion. Certainly the private sector providers would like to do it federally because of the economies of scale. It's just not possible to do it at the provincial level, even in Ontario, at a meaningful way. And if you can figure out a way to marry that to the financing formula, look, I think Health Canada and Shane Philpott made a very good effort at this for about 12 or 16 months there, and we didn't quite get to that point. Part of the blame for that, I think, is in the previous 10 years in Ottawa, there was no appetite for this, for which I bear some part of the responsibility in that regard. But if we wanted to think through a national quality legislation agenda, we want to think that through now and let it go after the next federal election and give it a 4-year run. That is a very complicated piece of design work, but it's well worth a 5-year think piece on that. I mean, it is very well worth doing some private work on that ahead of an election campaign. I was around for copyright reform. That was a 5-year process, and that's a relatively simple piece by comparison because all the tools are in the federal domain.
Excellent. Well, now I'm going to give the audience the opportunity to ask a few questions. And what we'd like to do is, if you want to ask a question, we have a thing called a catch box, which is a mic we can throw at you. It's encased in foam rubber, so it won't hurt too much. And so please, wait for the mic, because we also have people in a virtual conference, so we want everybody to be able to hear. And you could either pitch it at the panel or an individual. We'll leave it up to you. So first question, please say your name.
Okay. My name's Dale Kish, and I'm a Patient Voices Network.
You have to pick up the...
Oh, sorry.
Yeah.
The throw box or catch box.
That's your present for the day.
Yeah, that's my present for the day. And my question is, everybody's going around and around and around about where we're headed with this innovations and everything. The main objective and the main people in this is not only me, you, it's everybody, because we're all patients. And we all are the ones that are the important people in a situation. So we are the ones, even though the government's taking our money and saying, okay, we're going to give this much money here and this much money there, it's our money. And we are the consumer. So we have to be taken as a front runner on all these innovations. That's all I have to say about it.
Yeah, great comment. Thank you. Would anyone like to make a response about that? I mean, obviously the patient is paramount.
So I would just, I don't disagree with that, obviously, but I would just like to remind us that the Fixit Shop business that we spend, $242 billion a year in this country, only accounts for 20 to 25% of health. So that there's a lot, 40% of health comes from education, economic development. We can't lose sight of the preventive agenda, I guess, in all of that, so that, we're spending almost 50% of our entire provincial budgets on the Fixit Shop business, of which we know from many research studies in CI 2017 that at least 30% of that has no value and may in fact hurt people. Medical error is the 3rd leading cause of death in this country. Let's not forget that. So more care isn't better care. We have to get smart care and the right care. And I think that's where the quality comes into it in terms of data, because that's where we're coming into that era of big data. So I'm passionate about that because that's the world that we need to change.
Victoria, I think you have
I just wanted to add to that, because I think in addition to what Peter mentioned, the way we spend our health services right now is not only in Fixit, illness care, but also 5 to 10% of the population actually consumes 2/3 of our care. 25% of it is actually end of care. I think what we really need to do is to have some meaningful dialogue with the relevant stakeholders at all levels, because we talked about provincial, territorial, and federal government, but local governments actually also play a significant role in the determinants that Peter mentioned just now. And I also think that as a health authority that serves 1 in 20 Canadians, we hold public forums regularly, and we don't have the kinds of conversations that we should be having in those settings. Well, we have conversations about a specific care where, a bathrobe was lost, or, some of the care concerns are legitimate, but what we should really be talking about is how are we spending our healthcare services now? How do we actually smartly provide our services? Where should we be going with our healthcare services? How do we ration in an appropriate way our health services that's not indefinite? So I think we need to have some of these conversations, but conversations so far I don't think have been crunchy enough or meaningful enough.
Another question?
Good morning. John Sinclair with Novari Health. So I've been coming to this conference for a few years, and I've been struck that pretty much from Andrew's presentation this morning through to this panel, the word virtual care has come up on every one of these sessions. When we look at what's happening in the United States and other jurisdictions, Kaiser Permanente last year, 2016, 53% of their patient encounters were virtual. They were not face-to-face encounters, right? And the example you gave a few minutes ago also speaks to that. We're a small Canadian company in the health business. We're working with our partners in Ontario, the Ontario Telemedicine Network. We're rolling this out slowly, but there are barriers getting in the way. So I'm just curious as to how we remove those barriers. How do we get this done? It's a more efficient way to deliver healthcare. It can be a less expensive way to deliver healthcare. It doesn't really impact quality. So what's holding us back?
I'll start. I think I alluded to the post-medieval hierarchy. I think that's the structure that's holding us back. Machiavelli reminds us to change the order of things is the most difficult assignment because there are so few invested in the future and so many who are invested in the present. And Machiavelli says, and will maintain that interest with the passion of partisans. Okay, so it's really hard changing things. I've done that. And it's really, really hard to do that because you make a lot of enemies of people who are very happy with the status quo, and there are a lot of people who are very happy with the status quo. So the answer to your question is around, and Kaiser and others who are doing it, because they pay physicians differently. Mayo Clinic is run by physicians. It brings physicians in the tent. Every physician has a performance review every year. If you don't make it, you get kicked out. Those kinds of approaches to ensuring quality at the base end and bringing physicians inside the tent is monumental change in this country. In terms of how we currently have it. Look at how the federal minister, whether you agree with him or not on the finance side, wanted to change the structures around the corporate tax. The physicians were one of the most vocal groups in that regard. So, good luck. I can show you the scars making those changes, but changing the status quo and changing how physicians are paid as a part of this healthcare non-system is one of the biggest challenges we face.
So, Michael, I think that's the first time Machiavelli's ever been cited at an Infoway.
Need to invite more political scientists.
We have a question from the back.
The cube at the back.
Yeah, the cube at the back. So Penny Ray from Alberta Health Services. And I think one of the biggest challenges we have is how siloed and segmented the health system is, and every profession has a different group who thinks differently. And how do you see, or what do you see technology's role is or will be in trying to bring them together? Because unless we actually get people thinking collectively that the health system, we're not going to make big strides forward.
I can start. I think that's one of the big advantages of technology and data, especially because I think data is one of the areas that Canada actually is quite strong in. It's not necessarily we're strong in integrating what we have in terms of assets that we have available, but we do have a lot of publicly administered data that could be linked together for looking at solutions and even solving problems. So I think in a way, data, mobilizing data and finding those integration points is definitely a unifying point because you get those responses. We've recently looked at opioid epidemic, looking at data sets from emergency department, from coroners, from our emergency health services, ambulances, etc. And we did this unsupervised machine learning type of analytic, and what that did was to find clusters of people with similar characteristics. So in a way, that kind of data and analytics power attached to it will keep us honest.
I would like to make a comment as well. I think that it's my prerogative.
You're the moderator.
So, tomorrow, and I think we're here more, but I do believe, one of the focuses that we have at Infoway is exactly on that problem, the siloed system, and how we work across that as an organization with all the jurisdictions and partners and so on. And access is definitely a key area. Quality was mentioned by Peter, but I think we're also all concerned about access to services, how we get onto those services. And many provinces, there's small provinces, large provinces, there's very big differences in the resources that health authorities have and the provinces have. I think Infoway and others can play a big part in helping bringing together groups of provinces to work on common issues. And I think one of the big things we can do, and I'm going to kind of have this theme tomorrow in my talk, so I'll give you a bit of preview of it, but how Infoway can act as a catalyst to really bring all the things are there. Everything is there in the environment to do this. All the technology that is there, the resources are there, the will is there, but it's a matter of, in our disparate kind of health system, how can we bring together all the different groups and work on some real key and core common objectives. And I think there's a great opportunity to do that from a digital perspective. And we have another question from...
Hi, my name is...
Yeah, the top, yeah.
Hello?
Yeah.
It's weird, I know.
We can hear you.
Can you? Okay. So my name is Janica, and I'm a patient and family advisor, and I'm also living from Saskatoon. My involvement is with maternal services PFACs and children's services PFACs. My daughter has a rare bone condition called osteogenesis imperfecta. So I'm glad you mentioned the interprovincial, like the silo system, and trying to balance, because I know that there's different medication in different provinces, and it'd be nice for parents to be able to have that network and that access to why it's different in each province, and actually track some of the measurables, because there's not a huge amount of data on that. It's also really important to be able to get records of your specialist reports for grade-to-grade transitions for EA funding, for things that could be required for different diagnosis. In this particular case with the OI, it's a brittle bone disease. So constantly there's grant renewal funding, and it's a lot more convenient to be able to provide that to school systems for those grant renewals than to not have to leave work or school and then go to an appointment and then come back, and then you're missing that learning time as well. And already treatment time could take up a lot of that learning time as well. So that's on a personal level. I guess my question is how is it going to be able to be accessible for people in communities to know whether their doctor is on a program where they can provide that? Because currently I'm asking that of every single specialist and doctor. Some provide it digitally, some don't. And it's really inconsistent. And so I hope that's something that you guys could leverage or try to streamline. So
that's a very interesting question. I think there's lots of different approaches, as you said, and I don't know if the panel have any examples where local, perhaps, techniques could be nationally evolved.
So the best example I can think of, and it's a great question, I think that's part of that, how things are changing. I I think it's changing outside the healthcare system, and I think we need to have a real conversation as Canadians around the implications of that in this modern era, because it's not the 1960s anymore. And the example I'm going to use is from the UK, and that's called Babylon Health. Babylon Health is a virtual healthcare provider using AI on the front end that guarantees you an encounter with a physician 24/7, 365. There's a cost to that. I call it the Netflix of healthcare. It's £5 a month, roughly $9, if my translation of cost is right. So around $9 a month, you get 24/7, 365 access to a doctor, but not just any doctor. They only accept 1 in 100 doctors because they make sure the quality is there. And they have all of the quality certifications from the UK, and they're working with the NHS. They have 3 million clients in Rwanda. They have just over 1 million in the US. This is a global phenomena that we're entering into, and I think they have all the access to records. They have all of your information. They'll provide you all of that. They'll do e-prescribing. They'll do all of your care 365/7. So I think there's another world happening. People talk about Amazon, Google, Alphabet, or whatever, Apple. I think they are interested in moving into the health space because the status quo, the medieval hierarchy, the post-medieval hierarchy is so entrenched in the status quo, with few exceptions, few people who have been trying to change that for the past 45 years. But by and large, people are very happy in the status quo. The real change, the services that you want, are happening outside of the healthcare system. And I think the challenge for Canada and for all the provinces is, how do we deal with that? How do we deal with that in terms of our values? How do we deal with that in terms of our structures? So I think the big change, we haven't seen anything yet, but it's coming.
I know, sorry, can I just ask one more question? So I also in Saskatoon...
And then we have time for one after that.
Okay,
Yeah,
thank you,
okay.
sorry. So in Saskatoon, and in Saskatchewan, we have some of the most staggering statistics for HIV, and we're one of the only places where people still die of AIDS. Also, we have a huge epidemic of suicide rates in especially northern communities, and it's really difficult for communities to be able to access information or testing in a way that protects their dignity and the integrity of their care. And also, there's some talk about having care at home, but sometimes you need to leave your home to be able to have the privacy to access or gain, information on the care that you need. And I know you talked about understanding the science of adoption, and Ian, started off this panel by talking about consumer empowerment, and education outreach, I think, equals consumer empowerment. So, whose role is it to work with communities, or is there a way that, this group could have these types of dialogues in communities where, they would most want to access this type of data and resourcing? And also it could be a way to collect data in communities that aren't getting resources or have to travel or commute a great deal in order to get services.
I could tackle that with a quick response, and then I can ask if any further comment. I mean, there are actually a lot of initiatives across the country looking at different areas where you can improve communications, looking at tools like text messaging, social media, and so on in a clinical setting, backed also by clinicians and physicians. And this is one of the kind of core program we're looking at today. We're looking at working with some other organizations that have made progress in this area, particularly one area is youth mental health. And that's something that we think we can, help roll out some of these solutions at scale, on a kind of broader basis. So I think it's a great input there. There's certainly a big need for better communication, better tools for people to contact providers and reduce some of those barriers as well that exist today, and that's certainly something that we're focusing on. I don't know if any of the panel would like to make a further comment on that. If not, we have one more question. I think the front table here is dominating, but it's good to see we've got a lot of patients as well, so that's a good one. So the final question.
Yeah, Chad Dickey, I'm a patient partner from Victoria. I'm on the board of directors of AIDS Vancouver Island. My question is about the changing demands are driven by marketing, advertising, and for-profit entities that you mentioned. And I, as a patient, I'm skeptical about that because where's the trust? How can I build in the trust? And everybody else here as a patient, you should also, I think, are probably skeptical of some of the entities pushing some of the, so I'm wondering how can the trust be built, and how can I as a patient and you as patients trust what's being advertised out there? Other thing too is this ties into capitation and incentivization of delivery, targeted funding, and fee for service. We need allied preventative and maintenance care to be delivered as part of hospital care, part of emergency rooms, and part of doctors' visits. So do you think that this means that we have to update the Canadian Health Act? Because so much of this stuff is what's happening now with e-health, with virtual health, does not fit the model of what the Canadian Health Act means. It has to be updated, it has to be leveraged with what's happening now in the real world to change what is being covered through the Canadian Health Act and the relationship between the provinces and the federal government. Any input on that?
Well, that's two great questions. So what I'm going to do, I'm going to summarize that if I can. I'm going to ask each panel member to make a comment on one or both of those topics as a kind of final roundtable. But I think the first one is, with the advent of apps and everything, that many of which are commercial, can we trust those sources? And how could we have a system in place that we could trust them? Could the information be used for commercial gain? How do we know it's going to be really used for the betterment of our health? And then the second part is that should the Canada Health Act be updated to really take into account new technologies that are on the market? The Health Act was done several decades ago now, so starting with Ian then, give us your views. Thanks very much.
I'm tempted to answer the Canada Health Act question, but I'm not going to. Because I don't think the Canada Health Act is an impediment to very much. Every time somebody comes up with a list of things for me that they think the Canada Health Act needs amendments in order to permit, I find it's actually not. No, on the issue of trustworthiness, look, this is part of sort of the disintermediation in the digital world. This is manifest in the fake news, propaganda, all this other stuff. We're moving to a world of communities of trust, rather than having a single community of trust where institutions are authorized to confer trust on particular apps or particular processes or particular professions or whatever. We're going to get into communities of trust, and I think this is where the patient-driven side is going to be the most disruptive, because it'll be patient groups, either local patient groups or disease-specific or condition-specific patient groups here, that are going to form these communities of trust. Lots of people won't trust the one that you trust. That's going to take some time to work its way out. I don't see an alternative to that. As a university professor, of course, I hate it. I fear it. I'm part of the medieval guild that Peter Fingers here with trying to protect my privileges and my monopolies here. I'm part of the pillars that are jealous of the other pillars here. I want everybody to have to come to the university and take my damn class before they trust anything. But of course, every day I have students, I'm confronted with the fact that that's not the case. And so I'm in a battle to try and earn trust against my colleagues, against other universities, against other modes of educational delivery, and there's nothing I can do about that except do the best that I can. But the communities of trust are going to build themselves out, and I think there's going to be a period here of chaos where all sorts of communities of trust will turn out to be built on, castles of sand or whatever you want to say. But I don't see an alternative to that, except to do the best I can to establish my own circle of trust, because I'm sure I trust myself most of the time.
Well, I think I'm reminded of the presentation from New Zealand. I think they had a vision of what they wanted to accomplish. It was a very different vision from the status quo, but there was power behind that vision, and they implemented it. And why does it go back to your trusting? I think their organization is building trust with all these different stakeholders by offering services with with people that you trust, I guess you could say. And so they kind of become the ultimate triage portal, or let me try and go there and find out what would be the best thing. So I think, and they're playing a lot with the social medias and all that, so they'll be part of these communities. So I think I really enjoyed this presentation because they were leveraging all these things to do something differently, and at the same time changing the current system, because now if you have triage and people are in different roles, the people that ultimately see the patient would be different people than just the doctors. They're going to steer you to coaching, to other people, and so you're breaking the circle of care as we know it today. So I think building this vision is one of the ways we'll get there, I think.
So that's a great question. I just remind us that we base our current system on credentials. It comes from the word Latin credo, which means I trust. So I trust that you've got all your paperwork in order, basically. Now we know that that's not necessarily the case, and there are many examples across the country, hit the news all the time. I think we're sort of heading into a world where we have much more data at points rather than trust, and so we need to create that public data repository, if you will, whether you call it a platform or a gateway, whatever you want to call it, because I don't trust Apple or Amazon or Google to have the use of that data in my interest as a Canadian citizen. But I think that is part of what I call that quality legislation and quality dimensions of quality, access, cost effectiveness, customer satisfaction, all of those quality dimensions, I think allows us to update the Canada Health Act, which is, in my view, a nice, principle-based document, but we need to move into a data-driven environment that actually uses the mass amounts of data that are out there available in a way that benefits all Canadians. And I think that's what I'm talking about, and that's when I talk about quality legislation, is really at the root of that. It's about gaining trust for Canadians. Otherwise, we're going to be in a world that's worse than it is today.
Well, I'm going to do it differently. I'm going to go with the second question. And I think that the Canada Health Act, as a proud Canadian and our health system being where it is now, I think we do need to either look at applying the Canada Health Act differently or reinvigorating it in some way. And I think the reason that I say that is because I do think that there are broader roles for the federal government than it currently states, or the current space that it's occupying. And I think that is in the areas of where there are standards, governance, and economies that we need to look at. I also think that there's also specific roles and responsibilities for local governments and provincial territorial governments. I think there's roles and responsibilities and accountabilities that need to be clarified within the FPT as well as local government. So I think that's what I would say about that question. And the first question, I think really partnerships are critical to building that trust. And I would also say that partnerships, and then we need to deliver to actually garner trust. Unless we're able to deliver in those avenues that we're talking about, we will not gain trust.
Excellent. Well, thank you very much. And just on a final note, I think specifically in that partnership area, and also the role that we can play, I think, at Infoway is a big one here. For example, in our e-prescribing solution, we're partnering with the private sector, but we're doing it on behalf of the Canadians. And so we're making the best efforts to make sure that system is open, influence-free, free of kind of commercial gain, and it really is a tool for the citizens. We're entering a new field, really, I think, where healthcare has been delivered. Really, practitioners use private sector products to improve your health, but they've been delivered through a practitioner. Now you can access them directly, and that's a different kind of field I think we're entering. And with that, thank you very much. Thank you to my fellow panel members.